Welcome to Industry Insights. My name is Robert Balk. I'm a professor of medicine and pulmonary and critical care provider at Rush University Medical Center and Rush Medical College in Chicago, Illinois. And it's my honor today to be with you to talk about the role of interleukin 8 and its implications for the management of COVID-19 and hyperinflammatory ARDS. I have a few disclosures I need to make you aware of. I am receiving a speaker and consultant honoraria from Dompe, who is the sponsor of this Industry Insights. I've also been an investigator in past ARDS trials, as you can see from this slide. Let's start with a case, and this will be quite familiar to most of you in the audience. We have a 49-year-old male who presents with fever, headache, chest discomfort, cough, shortness of breath, no significant relevant past medical history, notes that several other family members have had similar colds. And on examination, we note the patient to be tachypnic, tachycardic, hypoxemic, hypotensive, and he has conversational dyspnea. Crackles on exam are heard diffusely, and he's lethargic in his mental status. His lab work shows a normal white cell count. He has mild anemia, a mild decrease in serum sodium and chloride, and he's hypophosphatemic. Chest X-ray reveals bilateral ground glass infiltrates, and that's confirmed on a chest CT, which also demonstrates no pleural fusions and no segmental pulmonary emboli. An echocardiogram is obtained, and he has an ejection fraction of 65%, no wall motion abnormality, and no right to left shunt on bubble study. The patient is intubated, placed on ventilatory support with low tidal volume, low pressure, ARDS-net protocol for PEEP and FiO2 titration, and you all know the story of how do we manage ARDS, and that is the objective today. We're going to review the pathophysiology of acute respiratory distress syndrome and the COVID-19 related ARDS. We're going to describe the ARDS phenotypes, highlighting the role of neutrophils and interleukin 8 and that complex interrelationship, and use that to help discuss current and future ARDS treatment strategies and introduce the potential investigation of IL-8, CXCR1, and CXCR2 therapeutic pathways that might be used in subsequent treatment strategies. So let's start with a definition, epidemiology, and risk factors for the acute respiratory distress syndrome. ARDS has been around for some 55 years. It's had various definitions over that period of time. Since 2012, we are dealing with what we term the Berlin definition, which was designed to basically emphasize what is the timing, that there should be a process that evolves within a week. There should be chest imaging evidence of bilateral disorder, usually bilateral opacities, and it's not explained by effusions or lobar lung collapse or nodules. And the origin of the pulmonary edema shouldn't be fully explained by cardiac failure, fluid overload, or hydrostatic edema if there were no other risk factors. And importantly, we've moved from the American European Consensus Conference definition, which talked about acute lung injury evolving into ARDS. And now we identified that based on oxygenation abnormality with PaO2, FiO2 ratio as a marker of oxygenation abnormality, you can define mild, moderate, or severe ARDS based on the degree of oxygenation abnormality while receiving at least 5 centimeters of water pressure, positive end expiratory pressure. So if we have mild ARDS, we have a PaO2, FiO2 ratio between 200 and less than or equal to 300 millimeters of mercury. Moderate ARDS would be defined as between 100 and equal to or less than 200 millimeters of mercury. And severe ARDS defined as a PaO2, FiO2 ratio less than or equal to 100 millimeters of mercury. Again, they should be on at least 5 centimeters of water PEEP. Preferably, if you're on severe ARDS, you should be on a higher amount of PEEP. And we know that there's a variety of causes and risk factors for ARDS. The more common ones are bacterial and viral pneumonia, and we've certainly all experienced that over the last 2.5 years, and non-pulmonary sepsis, but realize gastric content aspiration, non-cardiogenic shock, pancreatitis, certain high-risk surgeries and trauma may give rise to ARDS. And remember, we had a phase where there were a number of individuals showing up with ARDS related to having used vaping or e-cigarette products. And those spikes in presentations may give rise to an increased prevalence of ARDS. Certainly, we've seen an evolution in our ARDS incidence and prevalence. Up to about 2014, it appeared that in a multi-regional study across 50 countries, that ARDS admissions were relatively low, at about 10% of the ICU admissions, and about a quarter of the patients requiring mechanical ventilation. Well, all that sort of changed 2 to 3 years ago with the COVID-19 pandemic, and all of a sudden, about 33% of patients hospitalized with COVID-19 are ending up having an ARDS picture. And of those patients who were admitted to the ICU with COVID-19, about 75% of them actually had an ARDS-like picture. And you can see the sort of risk factors that we've all identified that go along with patients who present with COVID-19. We also know that oxygenation abnormality and severity of ARDS actually portends to the outcome. And here you can see the probability of hospital survival goes down as you move from mild to moderate to severe ARDS. And the mortality rate, even for mild ARDS right now, continues to be about 35 to 40%. So we still got a lot of work to do in order to improve the outcome of patients who develop ARDS. It's a complication of their medical problems. If we look at the COVID-19 related ARDS patient characteristics and their mortality, we can see as we contrast the COVID-19 versus other bacterial and viral causes of ARDS that the age of the patient population is quite similar. We have seen that the female sex is maybe a little less likely in the COVID-19. We've certainly seen a shift away from the usual racial disparity, and this slide doesn't include the Hispanic population, but we see that African Americans are a big aspect of the COVID-19 sort of racial inequality of who was affected by COVID-19. We see an impact of body mass index and the chronic diseases, diabetes, having chronic lung disease, all have a role in patients with COVID-19 ARDS. And we know that ARDS impacts the mortality rates of patients with COVID-19, as you can see as you move from just being in the ICU to developing ARDS to even having been on the ventilator with ARDS, that the expected mortality rises. So now let's spend a little time talking about the inflammatory phenotypes and response to the SARS-CoV-2 infection. So we know that the pathophysiology of ARDS is complex, and that is in part responsible for the lack of us having a single treatment for all patients with ARDS. And we know that the pathophysiology involves moving with inflammatory cells into the lung, into the vasculature. We activate PMNLs or macrophages. We end up getting interstitial flooding, coagulation, proliferation of interstitial fibroblasts, and we have changes in the endothelial barrier function so that now we've ended up getting migration of PMNLs. We end up having intravascular coagulation, endothelial proliferation, and we end up with a very intense pro-inflammatory and anti-inflammatory process. And the balance of those two may define what is the clinical course, as well as what is the response of the patient to various types of treatment that we provide. So we've talked about this intensity of either hypo or hyperinflammatory response. And based on the patient's hypo or hyperinflammatory phenotypic response, we can see differences in the outcome. We can identify the hyperinflammatory response as having higher levels of IL-6, IL-8, soluble TNF receptor, and even PI1 in the blood or plasma. And we know that these patients with a hyperinflammatory response will have less ventilator-free days, less organ failure-free days, and a higher 90-day mortality compared to those patients who have a hypoinflammatory response to their ARDS. Looking at that in more physiologic, mechanistic terms, we can see that in particular with the SARS-CoV-2, as it enters into the airways and binds to the airway epithelial cells, we have activation of T cells, macrophages, neutrophils, and those inflammatory products that these cells can contribute can then lead to an elaboration of cytokines, some of which may be so exorbitant that we call it a cytokine storm, which produces an inflammatory cascade similar to what we recognize happens in the early phases of sepsis. This can lead to multi-organ dysfunction, tissue damage, and even death. And we can see those cytokines and those inflammatory mediators and molecules can have variable effects on all sorts of different organs. If we look at a variety of different critically ill patient populations and compare them to our SARS-CoV-2 ARDS patients, we can see that the levels of TNF, IL-6, and IL-8 are pretty comparable when we look at the SARS-CoV-2 population compared with sepsis with ARDS, sepsis with no ARDS, out-of-hospital cardiac arrest patients, and trauma patients. So we've set up a group of patients with hyperinflammatory response, but we've also recognized that the SARS-CoV-2 related ARDS may actually have some additional unique features. There may be more predilection to lung fibrosis. There may be more peripheral radiologic features with a high likelihood of having bilateral lesions, predominant lower lung lesions. And one interesting note is that the COVID-19 ARDS patients seem to have more vascular enlargement. And that may be partly explained by the activation of the coagulation system that has been a major feature of patients with SARS-CoV-2. So let's talk a little bit more about the role of neutrophils, IL-8, and their role in producing neutrophil extracellular traps and exacerbating not only pulmonary disease, but even organ dysfunction. So here we see the complex relationship between the neutrophils and the IL-8 pathway in the development of ARDS. ARDS is facilitated by neutrophils, which we've already seen contain a number of inflammatory mediators and can elaborate cytokines. And these inflammatory cytokines that are released during ARDS can give rise to not only this cytokine storm, but can contribute to inflammation and to activation of fibroblasts, endothelial cells, the epithelial cells. And this complex relationship, as you see in this cartoon, between the alveolus and its capillary and the various airway cells and endothelial cells, as well as the other cellular components that happen to be in both those locations. And that is all participating in the response to try and neutralize the offending organism, but also gives rise to the injury we recognize as ARDS and even elaborated as part of the multi-organ dysfunction that may be associated with ARDS. Seen in a different schematic, we will demonstrate here the role of IL-8 and the CXCR1 and 2 binding sites in COVID-19 related lung injury. As we've said, the COVID-19 virus enters into the airway and binds to the epithelial cells. And then we have activation of vascular neutrophils, alveolar macrophages, endothelial cells, leading to more IL-8 production. The IL-8 production may stimulate the neutrophils to elaborate neutrophil extracellular trap formation, increase our inflammation, cause more infiltration of leukocytes into the lung and the vasculature. We get the vasculature and endothelial cell activated, which could lead to coagulation abnormalities, may then have more IL-8 recruitment, more cytokine elaboration, possibly the cytokine storm. And we have the immunopathology that we've recognized as part of COVID-19, leading to not only lung dysfunction, but other organ dysfunction, as well as immunothrombotic events, which, if unchecked, may result in the individual's death. So neutrophil extracellular traps are part of the compensatory mechanism to try and curtail the offending cause of the inflammation by killing the pathogen. And it involves having mature neutrophils, myeloperoxidase, neutrophil elastase, peptidyl arginine deaminase type 4, and other pro-inflammatory compounds to try and neutralize what is causing and amplifying the infectious process. But sometimes this process can actually plug up the vasculature and result in other downstream complications. And we've seen that net formation is common in other pulmonary diseases. And in fact, excessive net formation may contribute to lung injury and disrupt the microcirculation in the pulmonary alveoli. And we've seen that not only in ARDS, but it's been present in cystic fibrosis and COPD. And in fact, the more net formation that we see, it's usually associated with more severe disease and, unfortunately, more increased mortality and COVID-19 related ARDS severity. So net formation, while part of the defense, may actually contribute to unwanted outcome. We've also seen that IL-8 is elaborated in individuals who have ARDS and have lung injury, and also seems to correlate with the degree of ARDS and higher levels with more moderate severe ARDS in more severe COVID-19. And we've seen higher levels of IL-8 in the lavage fluid than in the serum. And it seems to be a good marker for identifying patients who have significant injury in their lung. And there's a variety of reports demonstrating that increased levels of IL-8 are seen in either the lavage fluid or in serum that go along with more severe ARDS with or without pneumonia, in having patients at risk for ARDS, patients who have acute lung injury, and patients who are critically ill with non-infectious lung injury. IL-8 seems to be a marker for increased ARDS, increased organ dysfunction, increased 28-day mortality. And in patients with SARS-CoV-2, we've seen that IL-8 has been associated with worse survival, with having more fatal disease versus surviving patients. We've seen higher levels in patients who have longer illness duration. And we've seen that higher IL-8 levels are seen in those patients who have ARDS at admission and who have higher degrees of oxygenation abnormalities. So IL-8 may present an option as a biomarker of disease severity, potential mortality, and could potentially be a biomarker to suggest a therapeutic target to help guide more directed therapy of patients with ARDS. So let's move to a discussion of current and future treatment strategies and see if we can move beyond our current 35 to 40% mortality by having more directed therapeutic strategies. So at the present time, our ARDS treatment strategies really evolve around the central providing lung protective ventilatory support. Using tidal volumes of 6 mils per kilogram per body weight has a strong recommendation from various critical care societies as one way to improve outcome. This is sort of one size fits all. We've learned that prone positioning for those patients with moderately severe ARDS with a PaO2-FiO2 ratio less than or equal to 150 did have association with improved survival. But we have conditional recommendations on using higher versus lower PEEP strategies and recruitment maneuvers. And beyond that, we don't have really defined precision-derived treatments for our patients with ARDS. We've had an evolving journey of how to treat our patients with SARS-CoV-2 ARDS, and we've gone from a variety of different strategies and have finally settled on using dexamethasone with or without tocilizumab or seralutinib if we need to treat somebody who is in what we think could be having a cytokine storm. Early on in the treatment, we were using remdesivir, and we know that baricitinib may substitute for tocilizumab if we have shortages. But beyond this, we don't have any other specific treatment for our SARS-CoV-2. However, we have a number of investigational strategies that are out there trying to now find some precision treatments, some directed treatments for patients that have either a targeted phenotype that we can identify that may benefit from specific targeted therapy to help us move into a time when we can say we have precision-related treatments for our patients with ARDS. And you can see there are a number of investigational strategies that are currently ongoing, and there are a number of attempts to use immunomodulating therapies for patients with ARDS that may lead us beyond where we currently stand with a 35 to 40% mortality rate. And we've seen some of these precision treatments have made their way into a little more of the mainstream. We know that for all patients, we are utilizing lung protective ventilatory support strategies with low tidal volume. We know that there are certain populations with oxygenation abnormalities with a low PaO2-FiO2 ratio, where some would suggest that there may be a benefit of prone ventilation, there may be a benefit of neuromuscular blocking agents, or using the open lung approach. We know that some patients with pneumonia requiring vasopressors may actually do worse when they are given open lung ventilation, so we stay away from that. We know that there are patients who have a good response to PEEP when they are hypoxemic, and they may benefit from open lung ventilatory support with a recruitment maneuver. And we know that patients who have a decreased response to driving pressure to PEEP may actually appear to benefit from open lung ventilation. And we know that if a patient has hyperinflammatory ARDS, that they may do better with open lung ventilation. They may do better if we avoid liberal fluid strategies and keep them relatively dry, where if they're hypoinflammatory, they may do better with a more liberal fluid strategy, and we know to avoid open lung ventilatory support. So as we're talking about precision treatments for patients with ARDS, it's important that we try to enrich our treatment population so that we're more likely to find a positive or a beneficial effect from the various treatment strategies. So we use predictive enrichment to help support finding that phenotypic population that may better respond to the therapy that we are going to investigate. And we have some predictive enrichment metrics that have been in play at the present time to help identify patients more likely to have that beneficial response, such as if we're looking to identify a population that has a high likelihood of fibroproliferative ARDS, we can look at elevated alveolar or serum procollagen peptide 3. If we want to find patients with a higher likelihood of oxidative injury, we can look at plasma cell-free hemoglobin. We certainly may want to differentiate between focal versus diffuse ARDS. We're going to talk about hypo versus hyperinflammatory ARDS as phenotypes that may benefit from certain anti-inflammatory strategies. And just like we have in oncology, some of the collagen vascular diseases and cystic fibrosis, if we can have a directed, personalized, precision treatment for select phenotypes of ARDS, we can then expect to have a higher likelihood of a significant benefit from that treatment intervention. And we can see evidence of that from the HARP2 study, which evaluated the use of simvastatin versus placebo in patients with ARDS. And when they separated the patients based on hypo versus hyperinflammatory response, they found that in the hypoinflammatory groups, the use of simvastatin did not seem to have impact on survival. However, if you look at the hyperinflammatory response, those individuals treated with simvastatin had a much better survival compared to those people who were given placebo, suggesting that an anti-inflammatory strategy in a hyperinflammatory ARDS population has the potential to improve overall survival. The same thing when we look at latent cell class response to help pick out hyper and hypoinflammatory ARDS related to COVID-19. If you look at the impact of corticosteroids in those patients who are hyperinflammatory, who did not receive corticosteroids, they had much higher mortality compared to the hyperinflammatory patients who got corticosteroid treatment. However, in the hypoinflammatory population, use of steroids did not seem to provide any benefit compared to those patients who did not receive steroid. In fact, the steroid patients seem to have a little bit higher mortality compared to those who did not receive steroids. So again, phenotypic presentation may have great impact on what might be expected based on the type of treatment, as well as what to expect in overall outcome. So we have a number of investigational anti-inflammatory therapies that are now being tested in those patients who have hyperinflammatory ARDS. And here's a list of some of these agents and some of the potential mechanism of action. You see, we're going through a variety of different anti-inflammatory strategies. So anti-inflammation targeting IL-1 receptor antagonists, targeting tyrosine kinase inhibitor, JAK inhibitor, or even targeting the IL-8, CXCR1, CXCR2 pathway inhibitors. So looking at IL-8 as a therapeutic target or treatment option in patients with ARDS. We know that ARDS has neutrophil recruitment, net formation, and that IL-8 is associated with both of those abnormalities. We know that IL-8 is associated with disease severity in ARDS, and IL-8 is localized to the lung. IL-8 levels may help refine treatment selection by improving our ability to target those patients with ARDS and COVID-19 that have more severe disease, as we can see from this nice graph where comparing IL-6 to IL-8, you can see that more severe elevations of IL-6 occur with severe disease, whereas IL-8 gradually rises from healthy to mild to severe. So IL-8 gives us a way to potentially even pinpoint more milder cases for earlier intervention in the progression of ARDS. We also know that when you look at targeting inhibition of IL-8 and CXCR1, CXCR2 pathway in small animal models, that it has demonstrated a protective effect for lung injury and a reduction in sepsis-induced multi-organ injury. We also have seen that IL-8 is not influenced by current anti-inflammatory strategies. As you look at levels of IL-8 in patients with COVID-19 treated with anti-inflammatory therapy, whether tocilizumab, corticosteroids, or even anticoagulants, the level of IL-8 did not seem to vary over the treatment time. So it sets the stage that there is potentially a good rationale for using a targeted therapy in hyperinflammatory ARDS, as we've discussed during this last 40 minutes or so, to try and modify the pathway as we move from infection through activation of the vascular neutrophils, macrophages, endothelial cells, elaborating more production of IL-8. If we use an IL-8 inhibitor, maybe we can modify that. If we're looking at the formation of nets and early hyperinflammation, more infiltration of leukocytes into the lung and the vasculature, an IL-8 inhibitor could have effects there, could have effects on net formation, netosis, elaboration of more of the cytokine storm and more of this inflammatory process that culminates in organ dysfunction, immunothrombotic events, more severe ARDS, and even death. So potentially, IL-8 inhibition has a role. And in fact, there are now a number of investigations that are looking at the use of agents to modify the IL-8, CXCR1, CXCR2 pathway to try and improve the outcome of patients with phenotypic hyperinflammatory ARDS. And here are just some of the potential agents, mechanism of action, and the status of the studies that are being either planned or under investigation to try and improve the outcome of hyperinflammatory ARDS. Well, let's return to our patient who obviously has ARDS. He's receiving lung protective ventilatory support with low tidal volume, low inflation pressures, and following the ARDS network protocol for PEEP and FiO2 titration. Patient has received dexamethasone, remdesivir, tocilizumab, was placed in the prone position for 16 hours a day for several days, and fortunately manifested slow improvement in oxygenation status. He remained hemodynamically stable and importantly developed no additional organ dysfunction or impairments or complications of critical illness, and eventually went on to be weaned and to make an uneventful recovery. However, what if the clinical scenario did not stabilize or improve? What would we have thought to do? Would we have given more steroids? Would we have given additional doses of tocilizumab? Would we have brought out other investigational agents to try and modify what we thought was a hyperinflammatory response? Wouldn't it be beneficial if we had a biomarker or other advice as far as knowing how to phenotypically address this patient's ARDS with a specific precision therapy? And hopefully the future will give us some precision therapies that will improve the outcome of our patients with severe ARDS. So in summary, the last 2 to 3 years have really demonstrated that ARDS remains a condition associated with high morbidity and high mortality, or unacceptably high mortality. Despite how adept we've seemingly become at recognizing and being able to support our patients with ARDS, we really need some therapies that are precision-based, personalized, based on biomarkers or phenotypes of the clinical presentation that will help us identify some specific therapies with the goal of improving the outcome of our patients. It appears that IL-8, CXCR1, CXCR2 has a central role in the pathogenesis and in the progression of hyperinflammatory lung injury. That pathogenic role may give rise to IL-8 as a potential biomarker to identify not only the inflammatory injury, but as a prognosticator of disease severity, to help us identify the response to therapy and predict the outcome. And potentially will have a therapeutic role as a precision treatment of those patients with hyperinflammatory ARDS. With that, let me thank you all for your attention and for attending this session, and thank Dompe for supporting this session today. I will open the floor for comments, questions, or other interactions. Thank you.